Hello, everybody, and welcome to our last Grand Rounds in the informatics program for this season. We'll be starting up again in September, and you'll have to check your email and other uh, publicity tools to see what we'll be doing next year. We're thrilled to, um, in terms of announcements in more general, we really don't have much more to say than what you've seen on the slides already. We do have some summer courses for you to take advantage of, and there's a whole lot of activity going on, but we're not going to go through all those details. So in the spirit of today, I'm thrilled to death to have our very own Alain Lebrique present to us. He has a great bio, professor, founding director of the Johns Hopkins University Global mHealth Initiative, and many others. The commitment that he has made to mHealth itself and mHealth in global health settings is remarkable, and has been a real model, I think, for the real notion that informatics is not just about the IT. And as much as he loves the IT, and we all love his tricorder that he got from the Star Trek folks, but he's really an embodiment of the notion that the IT is important only insofar as it really affects health in populations. Uh, and and I really, that's a lesson that I've learned from him, and I'm honored to have had that lesson be made. With that, I think there's no better person to let us know what's been going on with the pandemic and how precisely to avoid the shiny things that are in fact the IT, and let us focus on what's really important. So, Dr. Lebrique, take it away.
Good afternoon, good evening, good morning to all of you joining us on this informatics Grand Rounds. It's been a few months since the last one of these that I did, and it seems like the world has changed quite dramatically since we last spoke about digital health. And so today, one of the things I'm going to be focusing on is really talking about this major shift seen over, I will say, really the last 5 years, if not the last decade, moving into this space of digital health as a true health system strengthening opportunity. And as we think about the many ways in which this pandemic has led us to question status quo, and really ask ourselves, are we really doing the best we can to offer patients a human-centered, a patient-centered experience as they navigate health and ill health and wellness? And I think the answer is likely to be a resounding no, given what we've seen throughout the pandemic. However, the fact that we have been socially distanced and we have had to rethink the way we deliver healthcare and public health, I think also has allowed us during the pandemic to push boundaries that may have prevented us from trying things in the past. And I will say with rather positive experiences, as we've seen through the tremendous success that telemedicine and telehealth options have had during this pandemic around the globe. So as Harold said, I'm a professor in the Department of International Health with joint appointments in epidemiology and in health informatics, community medicine and School of Nursing, as well as bioengineering, innovation, and design. And I also direct the Global Digital Health, or mHealth Initiative. So it's my pleasure to be with you today. So I always like to start with this because I think this is part of what led me to enter into this space as an infectious disease epidemiologist. My training is in molecular biology, and I was doing large-scale community trials in rural Bangladesh, India, trying to understand ways to reduce maternal and neonatal mortality. Now, what you see here is a graph of a map of the world where country boundaries are being inflated based on the level at which, or pace at which, mobile cellular phone subscriptions were increasing between the year 2000 and the year 2011. And what's remarkable about this mobile phone revolution was that the very same countries that were experiencing this mobile phone revolution were the ones where we have been struggling for many decades to stem the tide of preventable maternal and neonatal mortality, together with numerous other public health threats in this sub-Saharan Africa and in the Asian subcontinent. And so the potential overlap here between uh, the problems that we were trying to solve and a potential solution space that we as a public health community did very little to actually grow at the pace that it was developing, as you saw in the previous slide, was really striking. And as we looked at the use or the potential of mobile telephony to interrupt some of the trajectories towards mortality, whether it was due to a lack of supplies, a lack of adequate decision making power, information gaps, or even communication between providers to other providers to get access to other opinions or protocols, were really worth close examination. And so, with I promised Harold that I would touch on the origin of my humble geek factor, and I've always been a lifelong aficionado of science fiction. And as many of you, or maybe just a few of you these days, might recognize this famous spaceship, which is the USS Enterprise, concept drawn up by an American science fiction creative thinker known as Gene Roddenberry, envisioned a future where we would have amazing technologies that would be able to enhance the way we operate as a spacefaring people. And here you see one of the officers off this Enterprise carrying a device that was, remarkable in what it was able to do back in the 1960s when this TV series first came to air. And if we take a closer look, we see that this tricorder that Harold was referring to a minute was a device that allowed you in the palm of your hand to look up information, to record audio and video, to communicate over long distances, and most interestingly, to capture vital signs at the point of need. So at the patient's bedside or on an alien planet, and to be able to look up information and also read these vital signs was just a tremendous future concept that they thought be far in the distance of human history. But here we are, and I would presume to think that almost everyone on this call has a device not too different from this one in their pockets or sitting on the desk in front of you. And that's the smartphone. The smartphone today has so many of these capabilities, and very soon in the future, if not already embedded in your smartwatch, we will see additional capacities to detect vital signs built into our ubiquitous smartphones that we carry in our pockets. But beyond Star Trek and science fiction, what we've seen in terms of the real world impact of mobile telephony is really remarkable. I was in rural Kenya a few years ago where we were in a small village of Kibwezi, where in this particular part of the district, there was no electricity, no running water. But as we went from to hut, one of the things I noticed was etched on the mud walls of these homes were long numbers, which my first presumption was these were certainly something to do with the malaria control program or the last national census. And our guide quickly corrected us by saying, no, actually, this is the mobile phone number. So if the person who lives in this hut is not there, we can call this number and get in touch with that person. If this happened to be a bicycle repair technician, and this was an easy way for someone to get in touch with them. So although this has really redefined mobile phone accessibility, and we think about this mobile revolution, There are still, of course, digital divides, depending on which continent or country you are thinking about. These divides tend to be exacerbated by socioeconomic status as well as by gender. Now, over the past year especially, and I would say going back to the middle of the 2010s, there was a concerted effort to try and define this emergent space that was looking at the intersection between digital communications or mobile telephony and health. And we began to in the early years of this field, the thing that we would refer to as M Health eventually diverged or devolved into this broader term, which we refer to as digital health. And you can see here, it's much more inclusive than just thinking about the mobile phone, because most powerful M Health solutions were those that were part of something larger than just whatever was on the phone or leveraged by the smartphone itself. And so this definition is the current working definition that large WHO, USAID convened digital health and interoperability working group is using to define this complex emergent space that I'll be talking about today. The systematic application of information and communication technologies, computer science, and data to support informed decision making by individuals, the workforce, and health systems. And of course, leveraging the last part, which many of you will be familiar with, coming from the WHO definitions of health and wellness. And so, over these past several years, well before the onset of the COVID-19 pandemic, we really began to see an acceleration of the formalization of digital health through a number of new organizations, new tools, new resources that really enshrined and codified the way we spoke about this field, the way we invested in strengthening in this field, and the tools that were being made available to countries and implementing agencies looking to expand their work and leverage digital health innovations in the way they conducted their global health business. And so, one of the most landmark accomplishments that I think a number of faculty at Hopkins were really instrumental to achieving were the first ever digital health guidelines issued by the World Organization, a process that took over, frankly, 6 years to go from inception to publication. And as some of you may be familiar with, the process of developing WHO guidelines is an extremely difficult and harrowing process that goes through an evidence gathering stage, followed by a synthesis and a guideline issuance by the normative agency for governments globally to consider as they make their investments in their health systems. These guidelines covered 10 primary domains, and this report is available online. And Stacy and Dr. Lehman have these materials, which they will be happy to provide on the DHSI website. But these guidelines have now been really valuable to drive investments at the country level into this space of strengthening health systems, leveraging digital health innovation. The other critical change that we've seen over the past decade is the precision with which we speak about this domain. And so, as I know, Harold is very particular about the words that we use in informatics. It's very important when you're dealing with an emergent space. Whether you're comparing an apple to an apple or an apple to an orange is very important. Whether you're trying to digest the evidence around that apple or orange, proverbially speaking, of course, but also when you're trying to understand whether the thing that I'm describing, when I use a term, a broad, all encompassing term like M health or digital health, is actually similar to you're describing when you're talking about digital health. So what I'm showing you on the screen here is one of the first efforts to speak about this space using these 12 sort of building blocks, if you would, to describe particular combinations and permutations of these building blocks to create particular in health, digital health interventions. We went from this very crude approach to classification to a much more sophisticated version of this that came out in 2018, which is also available on the WHO website, known as the Classification of Digital Health Interventions. And this is it brought together groups from the ISO, from the International Telecommunications Union, from the UN system, and more informaticians than you'd probably want in a single room to try and wrestle through all of the terminology that that was captured under this umbrella of digital health. And so one of the things that you'll notice is that this has been separated into 4 critical domains of intervention. The first being client-focused digital health interventions, the second being provider-focused interventions, the third being managers or supervisors of health systems, and the fourth being core data services. And so this helps us identify once again what are the ingredients of the particular soup that you have concocted to solve a health system challenge in your particular geography or health system. And so these are some of the definitions for these classes of interventions that you look at. The first 3 are fairly self-evident, and the fourth one really starts to refer to more of the cross-cutting functionality of services, including data collection, data management, et cetera, and data exchange. So for those of you who are dyed-in-the-wool informaticians, they were talking about health information exchanges and things like that. But to go back to a point that Harold was making in the introduction, and the title of this talk, not focusing on the shiny objects, it's absolutely critical. And part of the classification document that I just showed you contains this particular taxonomy, and that is the taxonomy of the challenges. So they have broken down health system challenges into 8 bins, each with a number of sub-bins, to really be able to address the question of what problem we're trying to solve as we speak about our particular technology. And I think this is absolutely critical. So the focus remains not on the technology itself, but on the problem that we're trying to overcome, leveraging this important technology. So over the past 2 decades, our group here at the Bloomberg School of Public Health and across the university, together with partners around the globe, we've developed a number of important tools beyond just how do we speak about digital health, but how do we evaluate digital health intervention. The first toolkit here you see on the left came out a few years ago, providing some exciting frameworks and indicators that could be used to assess the potential impact of digital health interventions. Other toolkits that have been developed cover things such as assessment of readiness for scale and sustainability, all the way through to current state and future state mapping using swim lane diagrams to better plan the implementation of digital health systems. So in the past, I've often had this conversation with informatics students who not too atypically ask themselves, when will I possibly use these skills that are being taught to me as an informatician? And believe you me, the world is changing rapidly so that your skills are going to be in high demand as digital health continues to mainstream, and the systematic approach to planning and executing these complex interventions is embraced more and more strongly in the global health community. So, just starting with the evaluation of digital health, we recognize that these projects are complex. If you go back to the taxonomies I just shared with you, it's usually not just one ingredient that makes up the soup of digital health that's being implemented. It's multiple ingredients addressing multiple challenges that are being deployed as part of a comprehensive, complex system. In this particular example from the Ghanaian MOTEC project, you can see a system described that has appointment reminders being sent to clients, messaging that is being broadcast to clients during the course of their pregnancies, as well as digital electronic health records in the background that maintain continuous prospective record keeping of client encounters. And so all of these systems have to be intertwined. There has to be back-end interoperability. There has to be semantic and taxonomic interoperability as these different parts of the system share information that is relevant to trigger events in other parts of the system. And what this means is we need to be more creative in the way we evaluate these systems, whether ourselves, do these systems achieve health outcomes, or do these systems accelerate, say, the quality and coverage of interventions for which we already know the inherent efficacy? So we no longer have to say, for example, show whether or not digital health intervention decreases the proportion of children who contract an infectious disease, because we know the intervention itself, that is the vaccine that we're improving the coverage of, is itself efficacious. So we can focus on interim outcomes such as coverage or quality of care as appropriate metrics of success for these digital health interventions. Then, of course, there is the importance of digital data exhaust and passive data collection that can be very informative about who is using the system, how frequently the system is being used, for what durations of time. That this data exhaust can actually speak volumes to how well a system is being used and its usability by the target audiences. A few years ago, one of the great frustrations as we embarked on the WHO guidelines development process was not only the dearth of high quality information about digital health evaluations, but also the lack of systematic reporting about the digital health technologies itself. And so one of our colleagues, Dr. Samisha Agarwal, who's now a faculty in our department, in collaboration with WHO colleagues and folks from around the globe working on digital health, came together and we developed the MIRA checklist, the mHealth Evidence Reporting and Assessment Checklist, which is a corollary to the PRISMA and CONSORT checklists that are used to report clinical trials or case studies, specifically to ensure that the quality of digital health reporting was consistently high, allowing us to derive value and make sure we would be able to integrate all of these research findings into the guidelines process. So a few years ago, all of this culminated in a fairly major sea change at WHO. And this to me was the seminal piece of evidence that when I think back to my first conversation with my department chair when I began to explore this field of mHealth or digital health, and I was told, well, that's all very nice, but hopefully you'll figure things out and come back to doing mainstream science sometime soon. And that was over a decade ago. And here we are with the launch in 2019 of a new digital health division within the World Health Organization under the chief scientist's office. So, we've gone from the lunatic fringe to as mainstream as it gets with a Department of Digital Health, yeah, WHO. And so the World Health Assembly now has had at least three digital health resolutions that have been proposed, enshrining as one of the priorities for the World Health Organization careful and systematic review of digital health interventions and recommendations to government and implementing agencies. The 2020 to 2025 global strategy on digital health was just released amidst the COVID-19 pandemic, providing very, very clear and unequivocal guidance that where appropriate, digital technologies to improve health should be used in a fit for purpose manner. And so, very, very exciting times to be working in this space. And so, one of the things that you can hear is, as Harold mentioned at the very beginning, that the philosophy that we not be chasing shiny objects has been very, very carefully integrated into all of this high level guidance that is emerging from normative agencies like the World Health Organization. You can see here in section 13 of this strategy that digital health will be valued and adopted only if certain criteria are met, right? So that if digital health enhances the efficiency and sustainability, that it helps deliver quality and affordable care, that it strengthens health promotion, et cetera, et cetera. So really not supportive of wanton investments in this space solely for the purpose of being as close to a start-like future as you can get. So the guidelines that I've been talking about look a lot like this. This is the guideline document that can be downloaded from the WHO website. These are the 10 domains that were prioritized for PICO review or evidence review, that the evidence around these domains was carefully synthesized. And this led to the issuance of the 10 recommendations that you can see illustrated here, a few of them on the right. Recommendations such as client to provider telemedicine. It is now a WHO recommendation that the use of client to provider telemedicine should be used to complement rather than replace the delivery of health services in settings where X, Y, and Z conditions are met. And so the same is said provider to provider telemedicine. And so on the left here, you can see the sort of patient journey and the recommendations that seem to cover birth to death and the use of technologies along this entire continuum. However, having said that, as we dig deeper into the state of evidence, I will say very frankly that we could and should be doing better. And so for those of you who are researchers in the audience and who are helping to develop this evidence base, evaluating and publishing work along this continuum, you can see here that the amount of information available for some of these guidelines was very, very sparse. And so even though we found in some cases either no effect with very low certainty, the record was still positive, largely because the cost of inaction was quite high, and the likely harms or risks to use these technologies was seen as very low by the experts who had been convened to consult on these WHO guidelines. But this is certainly something that we want to strengthen significantly going forward. And so given these evidence chasms, right, when we talk about ways in which we can value the utility of digital health investments. There's many other ways in which we can look at this. And so part of what the expert groups did was look at the economic costs. Is, for example, the use of a digital technology to notify individuals less expensive than mounting a face-to-face outreach operation with potentially an equivalent impact? Were there potentials for harm? Would we gain program performance outputs such as efficiency or time savings or paper burden reductions? And so, as one might imagine, the famous saying is we wouldn't do a randomized trial of whether or not to use email or Microsoft Office, although some might argue Microsoft Office can take more time than some other systems. But long story short, there are different ways of making this valuable argument for whether or not we should be adopting these technologies in context where the potential for harm is low and the potential for gain and system efficiency is potentially high. Now, just a few months ago, one of our most recent pieces of work came out under the title of Digital Implementation Investment Guide. And for those of you who are in the informatics program here at Hopkins, you will delight in the fact that this process is almost lifted wholesale from the training that you receive here at the Johns Hopkins University. And so it really is a very systematic approach. It's a guide for governments and implementing agencies to first assess the current state and the enabling environment, understand and strategically plan the implementation of the digital health intervention, bringing to the table all necessary stakeholders, having a clear vision of the future state and having those business process diagrams calculated very cleanly, making sure, and colleagues Hadi Karasi and Chris Shute will be ecstatic because the enterprise architecture takes a close and central role here in the middle of this process, making sure that architecture is in place to help sustain the digital health investments over time. And only then really beginning to define the health content, the decision trees, the various rules of the software that might be put into place. And then, of course, getting to the monitoring and evaluation of these systems to make sure that they are having the desired effect, followed by the careful and systematic scaling of these solutions once shown to work in a stable and consistent manner. And so you see here the sort of 7 steps with all of the tools and instruments that have been developed over the past decade, moving us well away from a world of shiny objects to a world of very almost, as Harold used to tell me, we prefer things that are systematic and boring because they often are the things that work the best and are unlikely to break under pressure. And I think I've done my very, very well in creating, a very, very structured approach to this with colleagues from around the world that might to some seem boring, but to anyone in the informatics space is absolutely the right way to go about building lasting and sustainable change. And so here's a sneak peek at what the implementation, we call it the DIG for short, the Implementation and Investment Guide. And you can see here the really, really outstanding way in which it's been laid out. And I welcome all of you to access the WHO website and download it and take a look for yourselves. So in plain language, for those of you who are not informaticians, here's what the DIG does. It helps walk through the process of defining with all the involved stakeholders what the system hopes to accomplish, define how things are done now. So, what's the purpose of these processes? How are they done? And who does them? What is suboptimal about the status quo? Where are the bottlenecks? Where are the pain points? And then, once those have been defined, asking the question about whether digital health innovations are appropriate to address those bottlenecks or pain points. There may be some bottlenecks or pain points that are addressed by improvements in training or remuneration, but there may be others that are fundamentally manageable through digital health innovations, such as supply chain monitoring and replenishment of commodities. But the important thing was not to reinvent the wheel. And so we have now created global databases of digital health innovations that follow these taxonomic principles, which allow us to ask first the question whether something exists as a solution before we invent a new solution to a problem that is well known and has been addressed by others. Once all of those pieces are in place, planning the implementation, integration, and monitoring and evaluation, costing out all of these components, and then being able to submit a costed plan to whoever is going to pay for all of these activities. So you can see here the approach that's taken. Here's a set of 4 typical processes that we encounter in a health system, ranging from patient management all the way to service delivery, and example workflows that are developed to describe these service delivery processes. Here's a process D that's been broken out by patient and health worker roles in the 2 swim lanes, and you can see how the main tasks and decision points are described. And of course, patient journey is filled with these many business processes and workflows that help describe that experience and that journey of the patient through the health system. Now, once all of those pieces are in place, we are able to describe the current state, how things are, and what we would like them to be using these various worksheets that have been developed as part of these systems. There are other things that hopefully you will learn over the course of your informatics training, including the development of personas and the identification of various drivers of cost. And all of these have been integrated once again into this fairly impressive piece of work that WHO has commissioned. And all of that ends up with, as we just described, the costed implementation plan, which can be taken to USAID, the Bill and Melinda Gates Foundation, or even the country's own Ministry of Finance to underwrite the work that will be needed to build not a one-off pilot project, but a long-standing sustainable implementation of a digital health solution. Now, a quick word about sustainability. And this is something that we've unfortunately learned from a lot of error, trial and error. And there are, as we like to say, the graveyard of digital health is overflowing with great ideas that just didn't have the right sustainability elements. And whether this was permissive and supportive policy environment that would continue to fund those digital health interventions, whether it was the technical capacity within government or the implementing agency to roll out and continue to grow a technical system, whether it was the cost components built in, simple things such as the need to replace devices and infrastructure, hardware on a periodic basis so that when a phone gets lost from the hand of a frontline health worker, they're not left high and dry, reverting back to scribbles in a notebook to conduct their central and key operations. And then finally, the institutional components that have to be present to make sure people are getting the maximum benefit from these interventions and that they see the benefit of these interventions and these digital health investments. The other important thing that we've learned over the course of this past decade is the fact that we can learn a lot from each other. And whether these are our successes or our failures, these communities of practice that have cropped up across Africa, across Asia, across the world, supported by the donor community and supported by large implementing agencies, encouraging folks to not invest in wheel reinvention, but to really share these experiences and where possible, share resources and technologies that can serve as building blocks for other technologies that are being set up in new geographies. We've developed tools to assess country capacity, and this helps to drive investments in the fundamental fertility of the digital soil, if you would, that enables digital health technology to flourish and grow. So, is there adequate leadership and governance? Are there policies around data security and data protections? And if not, rather than spend tremendous amounts of money in building point of care apps or diagnostic decision making tools, we should be investing in these backbone architectural elements that will then allow us to build upon for long-term sustainability and success. One of the things that the most recent evaluation using this digital health index has found is that public funding for digital health in most countries is minimal to absent. And so this is something that has to change if we want digital health to take off and be sustainable at the level we want it to. We know that security policies are often in place but not adequate. Privacy and data ownership regulations are not up to snuff, and that includes many states within the U.S. And I'll say that this last one is the most frustrating. Is the paucity of robust cross-border data standards. As many of you may have seen during this pandemic, even in the United States, sharing of data on a national scale was something that we did not do as well as we should have. And if this country in the U.S. cannot accomplish these things well, then it's difficult to imagine the challenge of data sharing across large swaths of the globe, where coronavirus is really having a major impact. And so, as you continue through a look at what are these various enablers, you can see that that across the board, these 7 sort of building blocks of the enabling environment, it's a sort of a C plus range of existing capacity. About standards and infrastructure and workforce capabilities and legislation. If we want to get to a 5, we've got some work to do before the averages go up substantially. This is the Digital Health Atlas, not to be confused with the Digital Health Index that I just shared with you. And the Atlas, as the name suggests, is this massive repository of projects and technologies that are being used across the globe, allowing governments to scrutinize what's being done in their country as well as in neighboring countries before they invest further in technologies that are being built de novo. And so if you are in the audience and you have a digital health technology that you're working on in a global health context, please go to the Digital Health Atlas, make an account, and register your innovation within this database. If this Grand Rounds topic has piqued your interest, there's a lot that we and others have been publishing on this topic. We recently published a systematic journal supplement in Global Health Science and Practice that did an exhaustive literature review in the 4 broad thematic areas. and that contains some recommendations for countries moving forward in this space. Groups at Hopkins and elsewhere are generating evidence across many different domains of digital health. Our colleagues in international health have pioneered a really exciting methodology known as the micro RCT, using random digit dialing and large population level deployment of different interventions to optimize mobile phone surveys, trying to find that sweet spot of getting the pulse of a population without the expense of door-to-door surveys that we in global health have been using as our staple, such as the DHS and other surveys that you may know about over the past many decades. So I want to say a few words before I close on some of the upcoming frontiers, and I'll say you in the audience are some of the first folks to hear about this if you haven't read the papers yourself, because WHO has just published this a few months ago, and these are the proposals to develop smart guidelines. It's tremendously exciting because it's the proposal to move, let me see if I can get my pen to work here, but to move from where we are now, which is level 1 narrative guidelines, like the ones I showed you a moment ago, which basically consist of a book filled with words that have recommendations on what to do and when to do these things, moving towards a space where we will have machine readable guidelines that can be taken up by digital systems that are in place in country, all the way to smart and dynamic learning modules that integrate local data in order to drive decision making about what should be done in that particular country based on outcomes that are being constantly integrated into the digital systems. And so this is truly, I think, for me, it was exciting to see an agency like WHO that typically has been criticized for not being forward thinking and cutting edge, really to suggest some revolutionary and exciting thinking in the near future. You can see here that groups have already begun to generate the type of underlying business processes that need to be documented in order for these sorts of smart guidelines to be implemented. And so most recently, the WHO antenatal care guidelines were digested or ingested, and the output that came from that ingestion was a series of very elegant generic business processes that could then set us up for developing the various software algorithms that might be necessary for smart guidelines. And this includes, not just the swim lanes, but also the specific rules that govern these various encounters. In addition to those rules, we have data dictionaries and other more sophisticated aspects of these digital systems that have also been published. And so our hope is that this sets the tone for dynamic and smart guidelines across the board, from TB to HIV to maternal and child health, underlined by or supported by digital infrastructure. So the result of this first foray into this space has been a reference application, or an interoperable, extensible application, if you would, for antenatal care that WHO has released in an open source manner, allowing countries to adapt, adopt, and modify this to their local circumstances. So another next frontier is, as you might have already guessed, AI machine learning, which it is part of the smart guidelines vision, but more and more groups are looking at the role of AI and machine learning, given the proliferation of digital health interventions. How can we harness more of this data to to drive improvements in diagnosis, improvements in decision support, improvements in science monitoring, and so on, as you can see here in this complex matrix on your right. And I would be remiss if we didn't come back to this, because I think although we talk a lot about person-centered care, we certainly have miles to go before we rest on any laurels that suggest we've achieved this, in whether we're talking about health systems in the global south, or we're talking about these in developed countries of Europe and North America. We have a lot of work to do before we are truly patient-centered or person-centered, not facility and clinician-centered. And so there are groups working on sort of rethinking and reorienting the model of care, empowering individuals, and strengthening accountability, and making sure that that care coordination is facilitated using these digital technologies. We have to keep in mind that NCDs, once the COVID pandemic is brought back under control, we will hopefully go back to recognizing the tsunami of non-communicable diseases that is driving the majority of preventable death around the globe, and the potential for digital technologies, whether through monitoring or feedback loops, or even providing incentives for improvements in behavior and performance, that can be used to try and stem this tremendous tide that we're seeing, that's causing such tremendous loss of life. And then, last but not least, I think this idea of really focusing on building up the enabling ecosystem, moving from the chaotic environment that's pictured here on the left, which is a map of Uganda in the early 2000s, with the number of non-interoperable, non-integrated systems that were deployed back then in 2011, which led to the Ministry of Health issuing a stop order for all of these projects. They could demonstrate that they were feeding into the national health information architecture, and that they were interoperable across the board. And so, in order to enable this, you need to invest in health information exchange architecture that includes things like registries and canonical repositories of clients and health workers and facilities that can then be tapped into by front-end applications that are used in the health system. We're also investing in global goods, and these are what I mentioned earlier, the building blocks. So if you need an individual text messaging platform, or you need a interoperability backbone or a client registry, you shouldn't have to go rent one or pay millions of dollars to get a big money company to build one for you. And so groups like Digital Square are investing in these building blocks, facilitated by donor agencies like USAID, who are allowing these Lego bricks to be built to facilitate country level use to generate these systems that leverage these global goods. And so if you're interested in this, you feel free to look at Digital Square Global Goods, and you'll be able to learn more about what's out there in terms of building blocks. And as Harold said, I will leave you on a final note. If you're not burned out by thinking about COVID and thinking about how do we use this as a moment to learn from and build resilience in our health systems, we have very early in the pandemic put together a comprehensive review commissioned by the Bill and Melinda Gates Foundation to assess a number of digital solutions for COVID-19 response around the globe, And I thought that this was a particularly elegant piece of work done by Dr. Agarwal and colleagues, looking at these 12 different domains and ranking and critiquing these solutions based on their performance across these different domains. So this is also available online, and I'll be happy to make it available to you as a group. And so within the report, these are examples of the types of overview sheets, and then more detailed reviews of the workflow and the capacity of each of these technologies. And so with that, I will say thank you, because I know I'm pushing up on time, and I'd like to take maybe 2 questions if time permits, as we think about what the future holds and this wonderful Gartner hype cycle that is published every year that allows us to see what things are in the peak of inflated expectations and what has survived the trough of disillusionment into productive use. And so thanks, everyone, and let me hand it back to Harold.
So that'll have to do for your applause, but thank you very much for condensing an entire course in global health informatics into 1 hour. Congratulations. It's really terrific. We do have I'm going to go backwards. Karen Kinder asked about why you didn't mention the SCORE tool. Anything you want to say about that? The WHO recently released a technical package of essential interventions, recommended actions, tools, and resources.
Absolutely, yeah. I know. I'm very familiar with the SCORE tool, and we're part of the consortium that helped to provide feedback on that. So thank you, Karen, for pointing that out. I will add that slide into this this already overwhelming deck. But yeah, it's a very useful tool, and then another mechanism to evaluate quality of health information systems. So thank you for bringing that back to the front of my mind.
Before then, Steve Miller asked about getting a little bit technical about BPMN and some of the other markup notations for workflow and business processes. Anything, there is the BPM Plus project, that's BPMN for healthcare. Are you guys using that? Is it relevant? Anything you want to say?
Yeah. So that's the kind of thing I would let the card carrying informaticians duke out among themselves. I think as you like to say, Harold, the lovely thing about standards is that there are so many of them. But I think underlying the question is really identifying, what is the standard that allows us to capture this information in a way that's parsimonious, that's clear, and that's extensible over time, and as more complexity is introduced into these systems.
I mean, and you made a great point about the backbone, but there needs to be pieces in that backbone. Is there any agreement about what that backbone is?
Well, so I will say in the global health context, given this investment in global goods, there is an initiative known as the Open HIE initiative that is getting a lot of traffic, and it's led by a South African consortium that is now being deployed in many countries around the globe, and I think the website is ohie.org. But they have now been adopted as a global good, and that interoperability toolkit is being made available to anyone who's looking for one. In terms of a standard, HL7 FHIR is really making a lot of waves, because it's I would say the first edition of this this standard that is transformatively different from its prior iterations. Its dependence on sort of the HTML model, but I think it also is appealing not only to low-income contexts and global health and public health, but also high-income, sophisticated hospital systems that are looking for interoperable systems as well. So
and
so I think HL7 Fire is really emerging as a very very powerful and
I'm glad you said the
strong.
right thing. There is a corner of Fire that is about sharing evidence using the same Fire, so that might be of importance for the evidence-based part of what you presented. Um, I think, Cameron, I don't know that we can get to your question. Um, I'll just do want to address Kerry. Smith asked about the new information blocking rules advance the cause of open HIE, but I don't know if that's relevant to the global health context. Is that correct? The U.S. has this new uh, against information blocking. Um,
Yeah, I'm gonna have to look into that.
okay.
I'm not entirely sure what carry is. That's
Terry will be happy to send you a little note about that.
sure.
That's a little joke. All right. Well,
Yeah.
we are at the end of our hour, and so Cameron, I'm sorry we didn't get to your question about the compromising, but thank you again, Alan, so much. Your fingerprints are all over these documents, and you're being very modest about all these accomplishments, and really, very for the community. I appreciate all the work that you've done for us. So thank you so much.
Thanks so much, everyone.
Take care. Bye bye, everybody.